Jim Schibanoff, we've talked a bit about the cost and investment requirements of adopting these systems. I'm curious also about the impact on providers of learning these new systems, learning how to use them effectively. Is this potentially a large burden for healthcare providers?
Well, it's great to hear Scott describe the after, because most physicians are dealing with the before, which they see as great disruptions to their routines of care, more inefficiencies in their practices. They feel under financial pressure already, and here it's taking more time to use this electronic health record. So getting over that hump is a significant issue. And in systems like the VA, Kaiser, I believe Group Health, there's much more of a group culture. There's a financial mechanism, a delivery mechanism. The physicians are more integrated into the system as opposed to all the physicians in private practice who are in 1 or 2 physician offices and may go to 1 or 2 hospitals. This is a significant challenge for healthcare. And there's a famous example at Cedars-Sinai Hospital in Los Angeles, which is one of the leading hospitals in the country, where they had to abandon the computerized physician order entry. That one thing that I said was everyone agreed was really effective in reducing medication errors. They had to abandon that effort and restart because of physician resistance. So we cannot minimize the importance of physicians. And as we at the CARE Guidelines think about physicians using the CARE Guidelines as an information tool at the bedside, which is sort of the holy grail of hospital care, the first thing we think of is physician usability. We need to design systems that are usable by physicians, some of whom are on the older side, who are not really that comfortable with technology. This is a major, major hurdle.
Scott Armstrong?
Yeah. So just 2 brief comments, Jim, and one in response to your points. It's true, and I've been through the transition with our medical group, and it's not easy, but I would also tell you that we are getting more applicants out of graduate school for every one of our open positions today than we have in the past, because they don't want to practice anywhere where they don't have this electronic record. And so we need to remember that. Second point I would make is back to your question about, well, what's it going to take for us to standardize this information and make it portable? I would argue that whether it's Microsoft or the VA or Kaiser or Group Health, we have very exciting pilot projects going on right now. And they are projects that we're going to learn a lot from. And I can't speak to the technical issues, but I'm sure we can solve a lot of the connectivity issues and so forth. But frankly, until we change the economic imperative, it's not going to happen. It'll happen by sheer force of will or some, economic interest of disparate companies. But the question would be, when will the care delivery system be economically motivated to invest in the clinical improvement that comes from electronic records? It doesn't exist today. It only exists in these closed systems. I would argue, and Ron was making this point earlier, electronic records will become ubiquitous much more quickly, universally connected too, at a point when they represent a real solution to how the care delivery system can be successful, promote better quality, return a decent margin on the bottom line for the healthcare organizations across our country.
So are we saying that, or are you saying that absent reform that would reduce or eliminate fee-for-service medicine, we're unlikely to see incentives for investment in these records?
I can't predict the future, but I believe that many organizations like those represented here will do heroic work to leverage existing technology and to try to create portability. But I don't think it becomes universally applicable like our financing system or our travel industry until we change certain features of the payment process and reform the system more broadly.
Well, representing, I guess, the largest payer at this table, in fact, I guess representing the largest payer of healthcare in the world.
Fear of, yeah.
Let's be clear that oftentimes payment policy becomes healthcare policy. And there's no doubt that we can incentivize providers to embrace technology. And in fact, that's what we're doing in these demonstration projects I mentioned earlier, whereby we're paying bonus payments to small and medium-sized physician practices to adopt and use electronic health records to report on quality data. Now, the direction that we are headed, actually, you mentioned, whether we abandon fee-for-service medicine or not. I don't know. The direction we're ultimately hoping to head, though, is for paying for greater value in healthcare and not volume of healthcare. Now, we can't get there without having a lot more transparency. You can't get to that transparency without having more of this data available. So that's sort of the step process we have to go through before we can get to that point.
I think it's appropriate to put some numbers out there. The cost to implementing an electronic health record is about $30,000 per doctor upfront fee, and then maintaining the record will run at about $500 a month, or about at least a half of an employee. So something needs to make sense to the doctor to do that. Now, most of the benefits of an electronic health record don't go directly to the doctor. They go to the payer, the insurance plan, or the patient themselves in safer care. But there's no business model to a private practicing doctor to recoup that $30,000 upfront investment and the ongoing $6,000 a year cost per doctor. Now, payment for quality and changing incentives can change that. I talked about online care. The medical home models that are being proposed by CMS and others, where physicians who coordinate care for people with diabetes and other conditions, that if they're paid a care coordination fee that allows them to work with patients to coordinate care, but that requires an electronic health record, because unless you have the data, you can't really do it well. So, let's say you paid $50 a month per diabetic for care coordination. Well, for 600 diabetics, that's $360,000 a year of care coordination income that a practice might get. So actually, those kind of thoughts could not only modernize especially primary care, the most on-the-ropes struggling area, yet it's the foundation of our healthcare system, that if primary care physicians are paid for care coordination of people with chronic illnesses, and the cost of the information systems could easily be borne by such a fee. And the evidence is that if Medicare, for example, paid a care coordination fee with strings attached, that it was real quality improvement, they'd actually save money. Because if you take better care of diabetics, they lower healthcare costs immediately. If you improve a diabetic, you can save $2,000 per diabetic per year in their medical complications. I mean, the amputations disappear, the dialysis rates go way down, hospitalizations go way down. So there really are win-win-win scenarios out there that could even include doctors in private practice.